Go.
Interventional radiology was consulted for an ultrasound-guided PICC placement. Patient is a 19-year-old male with cystic fibrosis, currently on veno-venous ECMO, secondary to acute respiratory failure. His brief medical history includes on 9/3, he presented with a bowel obstruction and is now status post-exploratory lap with small bowel resection ×1 and anastomosis. On 9/4, he had fascial dehiscence and is status post-partial closure and wound vac placement. On 10/28, he underwent a tracheostomy. He is currently MRSA bacteremic that is resistant to rifampin and vancomycin. All previous central line access has been removed, and his ECMO circuit was recently changed out to help decrease the infection burden. Active diagnosis and problem list include cystic fibrosis, acute respiratory failure, MRSA bacteremia, fluid overload, decreased RV function, pulmonary hypertension, coagulopathy, pneumothorax, status post chest tube placement ×3. Physical exam shows a 19-year-old male who is awake following commands on VV ECMO. Neurologically, he is mildly sedated on midazolam, dexmedetomidine, fentanyl, and propofol infusions. His infusions are currently being weaned down, and his propofol is titrated throughout the day to allow him wakeful periods to participate with PT and OT. From a cardiac standpoint, his heart tones are normal. He's got +2 pulses. He's warm and well perfused. Heart rates have been anywhere from 119 to 135. Systolic blood pressure 88 to 120. He remains on milrinone at 0.5 mics per kilo per minute for his decreased RV function. From a respiratory standpoint, his lung sounds are coarse. He has a productive cough. Respiratory rates have been 21 to 57, saturations 82 to 91%. He's got an 8 French Shiley trach in place. His vent settings, he's on an IMV of 20, FiO2 is 50%, PIP is 27, PEEP of 8, and pressure support is 15. His VV ECMO is currently running at 4.1 liters a minute. The circuit FiO2 is 100%. The sweep gas is set at 9.5 liters a minute. His chest x-ray shows improving aeration bilaterally. He remains on Q2 albuterol. CPT is Q4, and he's receiving Pulmozyme Qday. He was also recently started on a new CF medication called Trikafta, and he receives that twice a day. From an FENGI standpoint, his abdomen is soft and non-descended. Bowel sounds are present. He has a G-tube in place and also has an abdominal wound vac in place. He remains on Vital 1.0 feeds via his G-tube. He gets Creon enzymes twice a day. He's still on some total parental nutrition. He's, from a diuresis standpoint, he's on Lasix at 3 milligrams an hour. Diaril is 2.5 milligrams per kilo twice a day, and he's on Diamox 5 milligrams per kilo twice a day. From a hematology standpoint, he is anticoagulated on a bivalirudin infusion, which is being titrated based on PTTs and TEG-R times. He's receiving blood products as needed per the ECMO protocol in the institution. From an ID standpoint, he has been afebrile with a Tmax of 37.1. He remains on minocycline and daptomycin. His ECMO circuit cultures were positive daily times 10 days, and the last 2 have been negative this far. From a musculoskeletal standpoint, he moves all extremities, although he is very weak. He continues to work with PT, OT on a daily basis. And then from a skin standpoint, he's got his wound vac in place. He's got 2 chest tubes in the right chest, multiple areas of skin abrasions, and he's got a sacral wound that is healing. And skin team is also following him. So plan for the patient will be to place a PICC at bedside. Pain and sedation will be managed by the ICU team since he is on continuous infusions. Patient will be NPO for the procedure. We will continue the current plan of care per the critical care team. Anticoagulation will be managed by the ICU team during the procedure, and PTTs will be drawn every 30 minutes and adjusting the bival as needed. And then finally, mom was at the bedside. Procedure was explained. She was updated on the plan of care, and consent was signed.